So welcome back. I hope everybody is properly caffeinated. We are back for the old brewery mission, Policy Lab number 2. So we have Juma, Tuba, Carrie, Daniel, Akriti. And without further ado, I think you should just take it away. Thank you very much.
Thank you. Good morning, everyone. Welcome back. The topic of today's presentation is promoting continuity of care for people experiencing homelessness and alcohol addiction. And I, Akriti, along with my team members, Daniel, Kerry, Tuba, and Juma, will be presenting it. Our sponsor for the project is Old Brewery Mission, which works with people experiencing homelessness in Montreal, meeting their essential needs while finding practical and sustainable solutions to end chronic homelessness. The focus of our project is the challenges and barriers this population faces in accessing continuous health care to address their overall needs. For the purpose of this project, we did not make housing a particular focus, although we acknowledge there is close relationship between housing and health outcomes. The presentation is broken down into the following sections: an overview of homelessness, the policy challenge, an explanation of the healthcare system in Montreal, our recommendations and their impacts, other recommendation options that we considered, and an implementation plan, followed by a conclusion. Now, for the homelessness overview. The Canadian Observatory on Homelessness has defined homelessness as including a variety of living situations, such as people living without shelter, staying in emergency shelters, living in temporary housing, and those who are at risk of homelessness whose housing situations are precarious. Every year, almost 235,000 people in Canada and each night 4,000 people in Montreal experience homelessness. The point-in-time count 2018 study findings in Montreal showed that 23% of women, 74% of men, and 3% non-binary individuals experience homelessness. Housing, physical health care, and mental health services are the top 3 unmet needs, not necessarily in this order. And addiction is the most common cause of homelessness. Now, moving on to the next slide, our policy challenge is: how can OBM fill the service gap in collaboration with its broader healthcare providers for people experiencing homelessness with severe alcohol addiction that required specialized support? So why did we focus on alcohol addiction? Because studies have indicated that there is a high prevalence of substance use disorders among those who are experiencing homelessness. And substance use disorders are one element of the complicated healthcare needs of this population. In addition, this population may have past histories of trauma or current exposure to traumatic events on the streets. These experiences may contribute to their substance use as a coping method. The perception that addiction is a personal or moral failure needs to be challenged, as addiction is in fact an illness. Now, I will talk about the Managed Alcohol Programs, also known as MAP. The MAP is the one that aims to lessen the harm the chronic users of alcohol experience. The program involves administering a regular dose of alcohol at the shelter. As opposed to an abstinence-based strategy, this is more harm reduction focused, which is a set of practical strategies and ideas aimed at reducing negative consequences associated with drug use. As of 2019, there are 23 managed alcohol programs in Canada spread over 5 provinces. In December 2020, PAC, which is an Indigenous shelter serving people experiencing homelessness in Montreal, launched its managed alcohol program. OBM, our sponsor, it launched its pilot managed alcohol program in June 2022 to serve self-identifying men who live on a dedicated supervised site with the intention to serve up to 30 participants. Psychosocial services are also provided in addition to alcohol addiction support. Given the intensity of support provided by the MAP and staggered intake, our project aims the barriers that inhibit OBM and its partners from supporting the target population in addressing their healthcare needs before becoming candidates for the managed alcohol program. Now I pass it on to Tuba.
Great, thank you so much, Akriti. So moving on to the next slide, we'll now delve into our discussion of the interactions of people experiencing homelessness within Montreal's healthcare system. So similar to other healthcare systems, the one here in Montreal is quite complex in that there are a range of different programs and services offered for different needs, but we focused our analysis on the challenges and barriers experienced by the target population at 4 key aggregate points of contact. These include emergency departments within hospitals, primary care, specialized care, and in addition, we also explored the interactions between the target population and a variety of healthcare professionals at these various contact points. Our analysis revealed that people experiencing homelessness and alcohol addiction face numerous challenges and barriers in accessing healthcare services, but they are provided little dedicated support in navigating the healthcare system to access services needed, and they are not necessarily prioritized for services either. It is important to keep in mind that for this population, basic needs, including finding food and shelter, often take priority before their health needs. Their priority may also be finding their next drink, as without it, there may be severe health consequences, including seizures. Overall, we found that there is a severely fragmented healthcare experience for this population in which continuity of care breaks down at each of the key contact points mentioned earlier. Continuity of care is a complex and multifaceted concept, but it has at its core 2 key features. The first being the subjective experience of receiving flexible and timely care, and secondly, continuity across time and providers. Overall, we see the absence of continuity of care as a systems-level problem. The healthcare system in Montreal is not well equipped to provide holistic, coordinated healthcare services that are accessible and adapted to the complex needs of this population. I will now pass it on to Carrie to go through the key challenges and barriers that are likely to be encountered by someone experiencing homelessness at various levels of care within the healthcare system, including a brief discussion of care provided in shelter settings.
Thank you so much, Tuba. So here we go. I'll now take us through an example of a healthcare experience of an individual experiencing homelessness with a complex mental and physical health profile here in Montreal. This discussion will help demonstrate the often fragmented healthcare experience of this population that Tuba just mentioned. So first, we'll discuss health-related concerns at the street level. The experience of living on the street exacerbates pre-existing health issues among this population. While coping with their addiction, people experiencing homelessness often have to resort to consuming non-beverage alcohol, such as mouthwash, to prevent withdrawal seizures. And overall, the experience of homelessness and addiction clearly leads to higher rates of morbidity and mortality. So we'll move on to discuss the shelter level. OBM, as a private organization, is highlighted in blue here to help distinguish it from the broader public healthcare system, which we'll soon discuss. Organizations like OBM are providing healthcare services in shelter to help address gaps within the public health system. In addition to this new managed alcohol program, the PRISM program is designed to treat severe mental illness in shelter. However, capacity is only limited to 2 days per week. Mental health issues may also not be considered severe enough to warrant treatment with the PRISM program. And as the managed alcohol program is staggering their intake, many clients are not yet able to access this type of program. So let's now move on to emergency departments. So this population often relies on emergency departments for their care, as emphasized by multiple arrows going towards the left, towards the emergency department. Research demonstrates that people experiencing homelessness visit emergency care quite frequently, at 3 to 4 times the rate of the general population. In Quebec, a recent study found that among this population, substance use is a strong predictor of emergency department visits. Excuse me. So one of the challenges experienced by this population is also with respect to RAMQ cards, which is the Quebec Health Insurance Card, which are often lost or stolen while coping with life on the streets. As people presenting to the emergency room will not be turned away for lack of a RAMQ card, this makes emergency rooms more accessible. This healthcare setting, however, is ill-adapted to meet their needs, as the underlying mental health and addictions issues are too complex to be treated holistically within the episodic nature of an emergency room visit. There's also limited continuity of care, as different emergency room physicians are seen each time the person visits the emergency department. Even if their health concerns worsen, this population may also hesitate to even go to the emergency department and all levels of care due to past experiences of discrimination by health human resources staff, which is captured by the term staff attitudes within our example here. So moving on to primary care. Members of the target population may be on wait lists to be added to a family doctor's roster of patients for months or even years. Research also shows that the odds of this population having a family doctor decrease as time elapses on the streets. People experiencing homelessness as a result do not have a touch point with the healthcare system and therefore lack continuity of care. This population also faces additional challenges in making and keeping health-related appointments due to circumstances of living on the street. This population also as mentioned previously, as RAMQ cards are often lost or stolen, this further inhibits their ability to see a primary care professional. So now moving on to more specialized care. Without a family physician, this population often experiences difficulty receiving referrals to specialized care. Addiction services may be offered in buildings, as we learned through stakeholder interviews, that are physically inaccessible to people living with mobility issues, and be geographically located far away from where they usually live. Furthermore, high threshold organizational policies within specialized care institutions, such as codes of conduct where patients are not allowed to leave the premises of specialized care, may further discourage this population from considering this level of care that they need. They may therefore cycle through different levels of services without their whole complex health profile being addressed. So to summarize, some common themes have emerged, including a high reliance on emergency departments due to lack of access to primary and specialized care, a lack of continuity of care, and a fragmented healthcare experience. And overall, the complex mental and physical health needs of this population remain unaddressed, which may worsen their health conditions over time. Later in our presentation, we'll present this healthcare experience with the added benefits of our recommendations. And with that, I'll now pass it on to Juma.
Thank you, Kerry. I'll now talk about the recommendations, and first we want to highlight that we were not able to speak directly with people experiencing homelessness to inform our project, and we would highly recommend that OBM addresses this gap by engaging with this population on the recommendations, making adaptations wherever needed to align with their needs. On a secondary basis, we also acknowledge that all of our recommendations require advocacy efforts on OBM's part and buy-in from partners, particularly the Quebec public health care system. Therefore, putting these recommendations into action will depend to a larger degree on the capacity of various partners, external partners to engage. In total, we have 5 programmatic and policy recommendations for OBM and its partners, as well as the public healthcare system. So the goal of our recommendations is really to enhance continuity of care by increasing coordination within the healthcare system and improving access to healthcare services for people experiencing homelessness. Now, to evaluate these recommendations, we did consider 2 key criteria, the first of which is the likelihood of successful implementation, in other words, the feasibility, and the second, the impact on the target population, who are the people experiencing homelessness. So in terms of our recommendations, the first one is incorporation of health system navigators in shelters and also within the broader Quebec healthcare system. And some of the action points have been outlined in the slides. We won't go through them. But first, I want to explain what a health system navigator is. So the navigator supports patients with complex healthcare needs, such as the population we are looking at, to understand and navigate the health system by linking them with health services. They also educate patients about the healthcare system and how it works, and they may also engage with them to develop more appropriate long-term care. Now, our research has demonstrated clearly that health system navigation for people experiencing homelessness leads to increased rates of screening, usage of health care services, and retention in care, improved relationships with primary care providers, and also improvements in self-reported physical and mental health. Dedicated navigation roles can help to ensure navigators have sufficient time to establish expertise in navigating the healthcare system and help ease the workload of the nurses, the social workers, as well as case managers, who will then have greater capacity to perform some of their key roles. The health system navigator role should therefore be created both at OBM and within the Quebec public healthcare system. That's our key recommendation. The second recommendation involves piloting a publicly funded integrated community clinic targeted specifically for people experiencing homelessness and in partnership with the public system. So both the homeless serving sector and publicly funded hospitals currently lack sufficient capacity to prioritize and address specific needs of people experiencing homelessness and alcohol addiction, and this creates gaps that hinder access to and continuity of services for this population. So this integrated community clinic would be, we think it's an innovative solution that would address such barriers that we've outlined before. And intersectoral collaborative models of this sort allow the public healthcare system, homeless serving shelters, and other nonprofit organizations to work together to meet the unique needs of people experiencing homelessness. Our next recommendation regards training of staff interacting with with people experiencing homelessness on trauma-informed, person-centered care, both within shelters and within the the publicly funded hospitals. So here we are saying that trauma-informed care has been demonstrated to be effective in helping people experiencing homelessness to gain a sense of safety and trust in accessing healthcare services due to reduced staff discriminatory attitudes and also stigma. Likewise, person-centered care improves interactions through greater openness and conflict resolution. These skills, we think, are essential for the healthcare workforce to adopt in order to improve trust and build long-lasting relationships between the staff and people experiencing homelessness. Moving on to our next recommendation, recommendation 4 is about advocating for greater availability of low-threshold services. And here we are also saying that OBM should advocate for amendment of policies and rules within addiction and specialized services that present particularly high thresholds to access for people experiencing homelessness. So this could include, among other examples, sobriety requirements, as well as general policies that may limit hours of access or restrictions on mobility that prevent this population from using specialized services. In addition to these programmatic recommendations, our project also highlights several policy areas that appear to warrant new reforms. And our last recommendation on this, we call it policy review. So this draws attention to reviewing the wider policy settings affecting the healthcare system. So within the healthcare system, there are various policies at both operational and institutional level that create undue barriers for this target population. And OBM, we recommend that OBM should advocate for and participate in a review of policies that present complex challenges for people experiencing homelessness in their interface with the public healthcare system. So this could include, but are not limited to, the ones outlined. First of all, institutions and points of access to the system, and this could include the location as well as physical accessibility of services. Secondly, regulatory policies, and these are the ones that could impose conditions and requirements for accessing services, such as the one outlined by my colleague Kerry on RAMQ cards. Lastly, we have funding and incentives with regards to exploring options to increase incentives for family physicians to take on people experiencing homelessness within their roster for patients. So we do believe that these recommendations serve as concrete opportunities to make healthcare system level interventions to help adapt the system to better respond to the needs of people experiencing homelessness, and as a result, to feed into our main objective of this project, to improve the continuity of services for this population. So I'll now hand it over to Daniel to help us visualize the impact of the recommendations that we have outlined upon a successful implementation.
Cool, thank you, Gemma. Hi, everyone. So now to summarise what we expect to see as the main impact of our programmatic recommendations on continuity of care from the perspective of a member of the target population. The likely effect of the review itself is not shown on this slide, as the first four recs are the ones that we expect to have a more direct impact here. Let's start by thinking about the options available to a member of the target population, beginning with OBM. OBM will be providing a trained navigator on site, and their staff will be better trained in trauma-informed care. Moving on to the integrated community clinic, that provides a completely new point of care for the target population. And it provides it in a way that looks and feels fundamentally different from the types of care that they can normally expect to receive from the public system, despite the fact that the clinic would be publicly funded. And as in OBM, we see a role for publicly funded navigators here. Now moving on to primary care. We see no immediate change for existing primary care providers, besides the training, but the review that we're recommending does touch on some of the more systemic issues like GP allocation and prioritisation. Specialised healthcare could be provided in more in quite different ways, I should say, compared with what's normally what's presently being offered through the availability of low threshold services, in addition to the sorts of service offerings that are currently available. The review also touches on issues like centralisation of addiction services, so navigation of those services could be expected to be easier. Finally, we also expect to see reduced use of emergency departments overall, but where people experiencing homelessness do present to emergency departments, we still expect them to be provided with better navigation and better trained staff than they currently receive when they present there. So let's take a moment just to step back and think about the needs of our patients and how this maps on to what those needs are. Their health needs are still going to remain very complex and very difficult for the system to address. And a lot of the needed treatment that they are going to need to receive cannot realistically be provided at OBM or the integrated clinic or for that matter, emergency departments. However, the presence of navigators in all three of those places aim to smooth the continuity of care by identifying linkages with the places that the population are most likely to need to go, helping those patients identify their health goals and what they want to work on, and ensuring as continuous and as friendly as possible an experience as they go between appointments. We also expect that the integrated clinic and establishment of navigators will lead to more and better lines of communication between homeless serving shelters and the public system, which will hopefully support the system in providing better continuity of care. Finally, we also expect over time that training will help ensure a more personal and human experience wherever members of our target population do end up going. I now want to move on to briefly touch on some of the recommendations that we considered but eventually discounted. The three options that I'm going to discuss here were all contained in our draft report but subsequently dropped. We're discussing them now in the interests of providing greater transparency about the recommendations we did end up providing, as well as our thought process. So for the sake of time, I'm going to talk about the first two together. We considered off recommending health outreach services, which is essentially a mobile form of healthcare with teams going out into the street where we expect people experiencing homelessness to be and offering care there. We also thought about recommending just more care provided in shelter along the lines of PRISM and other such programs. Both of these were dropped because of practical constraints, and we were unsure what they would offer over and above what's already being offered in Montreal. The more fundamental point is that they both aim to provide new and better options to the target population over and above what they get in the public healthcare system. We decided that the integrated clinic was a more effective and more potentially impactful way of achieving that objective, so we substituted that recommendation for these two. The final one I just want to touch on briefly is RAMQ storage. So we were looking at ways here to essentially mitigate against the likelihood of theft or loss of RAMQ cards. We discounted that because the options that OBM and others are already providing are enough that we didn't think that we could improve upon those. The review still touches on questions of whether RAMQ cards are even needed for all the care that people currently receive. I'm now going to hand over to Tuba, who's going to wrap up and discuss our implementation plan.
Thanks, Daniel. So in terms of our implementation plan, we've come up with concrete activities for each recommendation as outlined on this slide. But in the interest of time, our main purpose here is to highlight the proposed timeframe for implementation of each of the recommendations to give you a sense of the practical sequencing of these recommendations on the ground. So to start, we see navigation and training as short-term recommendations that we consider to be incremental improvements to the healthcare system, and therefore these can be implemented relatively quickly, potentially in less than a year. Next, we view low-threshold services as more of a medium-term activity, taking between 1 to 3 years, given the need to review existing policies and make amendments where needed. And finally, the integrated clinic and policy review would be implemented over a longer-term horizon, as these represent large-scale changes to the healthcare system. So to wrap up our presentation, we'd like to briefly summarize our key findings. People experiencing homelessness and alcohol addiction face persistent challenges accessing healthcare services. These challenges result in a fragmented healthcare experience in which continuity of care for their overall needs breaks down at multiple contact points, from primary care to specialized care, and in their often stigmatizing interactions with healthcare professionals. Our recommendations are designed to improve continuity of care for this population, both within OBM and the public healthcare system more broadly, leading to improved access to primary and specialized care services, including on the basis of improved interactions with health professionals that facilitate trust and create a sense of safety in healthcare interactions. Ultimately, to properly meet the complex needs of this population, we envision healthcare services that are adapted to the unique needs and realities of people experiencing homelessness. Our recommendations for an integrated community clinic and greater availability of low-threshold services in particular are intended to move the healthcare system in this direction. And that concludes our presentation, and we welcome any questions or comments.
Very well done, folks. 20 seconds away. Okay, first questions are to the judges. Who's first? Nadidi.
Thank you so much for your presentation. This is a very important topic and very relevant for our time. So thank you. So I have a few questions. The first one is, as I was listening, a few things jumped out at me. So OBM has its own mandate. I was looking at their website. And obviously there are things within its control and things it can do. And then there are aspects of this that have to do with the broader public health ecosystem. But your recommendations seem to combine both. So can you distill that for me? What is within their sphere of influence? What is outside their sphere of influence? And what is the enabling environment required for this to take off? The second question is, a huge part of this intervention is the role of the family and community care and post-care. And you don't really address that at all, right? Where does that fit in terms of sustainability? And then the final one is funding. I just looked at OPM's website. The first thing that popped up was fundraising. Where does the money come from to do all of this? It's expensive. Why hasn't it been done before? Resources, people, etc. Where does that fit in? So lots of questions, but I'm sure you can answer them.
3 questions. One person or 3 people?
We can divide it up. Okay, I can start. So thanks so much, Nadidi, for your questions. So the first one was about like OBM's responsibility, how does it fit in versus the public healthcare system? So our first recommendation around navigators, we're thinking ideally, hopefully the budget would come from OBM, even though this might be challenging. They have some constraints as a not-for-profit private organization. The average health system navigator's salary is about 44 grand per year. This is pretty conservative, but we're hoping that ideally, fingers crossed, that OBM might be able to implement that. And then with the public healthcare system navigators, that would hopefully come from public monies to fund that within hospitals here in Montreal and community clinics. You were asking as well, oh, sorry, the community side. Did you guys want to jump in? Okay, great. Thank you.
Yeah. So if you look at the integrated community clinic, there's only so much that OBM can do on that front. So that's why our key recommendation there is for them to advocate for this to happen in partnership with the public healthcare system. So OBM essentially has a lot of expertise in terms of working with people experiencing homelessness. And so the essential role there is to shape the services that are being provided for this population in terms of what to provide to meet the needs of people experiencing homelessness, and to advocate in partnership with other shelters in Montreal and also nonprofit organizations that provide healthcare. So we see OBM as being taking a lead in terms of advocating for this to happen, and it's in the long term. So I think OBM does not have funding to really implement this, but that's why we recommended that they take lead on advocacy for this to happen. Yes.
Yeah, maybe I'll add one more quick point. So as Juma mentioned, there is a limited role for OBM here with respect to what they can do, right? They are not the public healthcare system. And so the remaining recommendations that we didn't speak to, so those being the policy review, low threshold services in particular, those are 2 areas where we see a strong advocacy role for OBM, as Juma mentioned, in their interactions with the healthcare system to put forward the business case and the rationale and the need for the system to take responsibility to adequately provide care that meets the needs of this population. And so that's kind of how we see it come together.
Leslie?
Okay, well, talk about a wicked problem. I mean, this is a real tough one, right? You've got a system, a healthcare system that's broken, quite honestly, for individuals who are experiencing homelessness and often will have addictions. And then you have wonderful organizations trying to work under these conditions, right? So I think you've done a nice job trying to lay out some potential roles for OBM. And there were a couple things in the report, like one that kind of, to me, fell off the radar. And I'm not sure if it's in one of the nuances that's discussed that I'm missing. So I'm hoping you can help me with this. So it's with respect to secondary trauma of the individuals who are working. For example, in OBM, the navigators would most certainly also be in this particular space. You talk about this training of navigators, in particular, like this patient-centered care, et cetera, et cetera. Are you envisioning that training would also include and address secondary trauma, which results in high turnover rates, right, among the individuals who are working in places like OBM or potentially the navigators? Can you speak more to that?
Yes, thank you, Leslie. So we looked at trauma in two fronts. One was trauma faced by the people experiencing homelessness. So one, this could be early childhood traumas. And secondly, this could also be traumas that they currently face in their daily life in the street. So that was one aspect. And then the second aspect was from the staff that work with these people experiencing homelessness, because of the high, the burden that they have to face every day working with these people, the pressure. There's not a lot of staff to share responsibility. So we thought about the two aspects, but we thought that the services could be provided to address the trauma faced by the people experiencing homelessness. And then we thought about the wider policy setting that would address issues to deal with, for example, low wages that leads to high staff turnover rates. And so we thought that could be handled by the wider policy review process. But then in terms of training, we thought about making this an annual thing, and also when employing new staff to include these training modules in the onboarding process. Yeah, I don't know if that clarifies
that
it.
helps clear it up for me. Thanks. And then another question. This truly is a very tough challenge, and one of the concerns that I have is I like the idea of the navigators. Absolutely, I think it's a great idea, and you definitely provided evidence to support that would be helpful. It seems, though, that they're navigating people into this broken system, right? And so that's always the challenge right here, is that you're moving them into a broken system. And in some respects, you started to create a new system, which I thought was a great idea, like this pilot integrated community clinic that you proposed. I was kind of surprised that you didn't go with the mobile option, right? And so I'm curious if that was primarily only a cost situation, because you proposed other things here that could be costly, right, and would require the advocacy route to get funding for. But were there other reasons why you dropped kind of going into the field or bringing healthcare practitioners into the field, like any evidence that was out there that suggested that doesn't work?
Okay, all good. Thank you, Leslie, for your question. So for sure, in the research, we've heard of a term called navigating to nowhere. Yeah. Right? So if there's not the needed services they need, where are they actually going to navigate to? So that's kind of like a well-defined problem. And that's why we wanted this integrated clinic to be this new service, so that these navigators actually have like a adapted service where they're actually navigating to, as opposed to this navigating to nowhere challenge. And then in terms of outreach services, there's Montreal existing services that are providing outreach. So Médecins du Monde, which is like Doctors of the World, and they're already providing some of that outreach. And so that was part of the reason why we thought maybe not so much the outreach, but the navigators and the new clinic. So hopefully that helps. Great. Thank you.
The final judge question before we pass it off to the sponsors, and we have our sponsors online on Zoom. So my question is about access. I think your report really highlighted some big access issues that I had never considered. And just that notion of the RAMQ card either being lost or stolen, like, I mean, we're supposed to have an open access and free healthcare system, which clearly fails in our more vulnerable populations. So as a Quebecer, I'm still a little shell-shocked by that one. Good. My question is, the Quebec government recently published their strategy on homelessness. And I wonder, do they know? Was this mentioned in their report? Do they have a plan and strategy for how to address this? Because I don't think we're going to abolish the RAMQ card, but clearly we need to find a way to allow our vulnerable populations to get access to free healthcare. So I'm just wondering, what is the level of consciousness of the Quebec government in understanding that this issue exists, and what are their thoughts on how we need to fix the problem?
Okay, I can take that one. Yeah, so this is a really good question, and this is something that we had to think about quite a bit. So the short answer to the question is that the Quebec government has thought about this issue and done things about this issue. So there are special provisions within the regulations acknowledging the fact that people experiencing homelessness by definition don't have a fixed address and have particular challenges accessing a RAMQ card. So some of those issues are there, and there's, as I mentioned in the presentation, there are also policies that are, or there are also things that organisations like OBM do as well. In terms of the action plan on homelessness, that has a general commitment towards exploring issues around RAMQ cards. But I think for some of the reasons you were getting at, it's quite a hard thing to actually to actually do a lot on, because they exist for a reason of helping providers access information they need to, while also protecting patient privacy. So it is on the agenda of the Quebec government, but there's not a lot specifically that I'm aware of that they're doing over and above those sorts of exemptions.
Okay, Natalie, we're turning over to sponsors who are you going to manage the sponsors who are online, or how do we do this?
I can see the chat, so I guess my call out would be to Jim and Hannah to give us your questions or your comments to the team. I think that's what we're looking for here. And I think we're going to unmute. So Jim is now unmuted, and Hannah is too. So take it away, Jim and Hannah.
So I'll go first, and Hannah will wade in afterwards. So listen, we've spent a lot of time with the team, and what a journey you've been on. Thank you for choosing this sector and this issue, because it does receive so little attention. Just on the last question, homeless people with very, very high needs are really not a priority at all in the Quebec plan that was put out recently, which wasn't a bad plan at all. But this particular subset of people, which does receive, as the team has said so eloquently, so little attention and so little priority within the existing system, really would benefit from hearing what we think the policy team has put forward. So we're, really, frankly, very impressed how it's all come together. Not just what you did actually put forward, but what you didn't. Very, very interesting to see what actually the final product was. So congratulations to you. The idea of navigation is, I think, is one whose time has come. Just to say, as a general statement, the system is broken. I think perhaps a generalization that is not necessarily true in all cases. And in many ways, the navigator trying to help and identify corridors into service, both within the nonprofit system, if you will, and the parallel and complementary public health system is precisely what they're there to do, which we try to do, we do our best to do already, but is exceptionally difficult to do, and it's a specialty. We've seen it in other areas, cancer treatment in particular, where it's been very, very effective in helping very high needs, high complex people to get treatment in time from the right professionals. So I think it's a really interesting proposal. The integrated clinic as well is one which is something we dream of, and thank you for articulating the dream in a better way than we have. To be perfectly frank, I think it's just a terrific overdue idea. Primary health care is just simply not available at all to 30% of the population, and basically to 0% of the general population and 0% of the homeless population. So that's another layer of navigation as well. It's not just treatment, but also navigation. That's what GPs can do. And I think the idea of a clinic that prioritizes primary care and other forms of care is another idea that's overdue. So I think I'll stop there, and once again tip my hat, thank you, and we feel like we'll, to some degree, we'll be lateraled the ball. You're pitching, we're catching, and we appreciate it very, very much. Congratulations.
Thank you.
Thank you. Thank you. Thank you.
Hannah as well.
Hi, yeah. So just to echo what's been said, congratulations, team. This is a tremendous challenge. Like everyone has said, we didn't serve you anything simple, but inevitably in our line of work, there are no real simple challenges, if you will. But this certainly is one that is a recurring issue that we deal with in our services, and I'm very grateful that you guys took this up with such gusto in such a frankly short amount of time. Furthermore, my question that I have for you guys, since unfortunately given the timeline and certain other restrictions, there was no ability to go and interview people currently experiencing homelessness, currently dealing with these access issues. So my question for you guys, now that you've developed this sort of rich expertise around the issue, especially at this high policy level, if this project were to continue, if this research were to continue, and you were given the opportunity to go into the field and have a conversation with individuals who are dealing with these access issues, what would be some of the questions you would want to ask them? And I say this, in a little bit of a self-interested way of like, can we take this once again laterally and then even refine really our understanding of what these needs are? So perhaps it's too big of a question, but I'd be curious to think, what would be sort of some of the things that you would like to fine tune with people dealing with these access issues themselves?
I've got thoughts on this. Yeah. Thanks, Jim and Hannah. That's very good to hear from both of you. In terms of your question, Hannah, I think there are two questions that I would start with asking people in that situation, and these are both quite general, so bear that in mind. The first one is questions about what services they're aware of. There are 5 of us, and we've spent, as you know, quite a lot of time kind of trying to think about the system and what's available. And it's, as you know, it's hard. And so I think knowing what people experiencing homelessness are and are not aware of is a very key one. And I think the other one that follows on from that, where people in the target population are aware of services, is being quite open-ended about why they don't use those services more if they would like to. Is it because they don't meet their needs? Is it because of some other barrier? Those sorts of things. And being as open-ended as possible, I think, is the way I would start with those sorts of questions. Does that answer your question?
Anybody else want to add to?
Yeah,
that?
just to add to what Daniel said, so while asking them questions, we'll just be more cautious so that their past traumas are not, just come up again. So we will develop some strategy and, to contact them that way. Yeah.
Yeah, no, that's good insight. And I think you guys are on the money in that it has to be sort of open-ended and ask less I think driven questions in this regard wouldn't be as useful so much as is that we need to think broadly about what the questions of access are from people's perspectives themselves. So thank you for that. I appreciate it.
Hannah said there are no simple challenges. Should we have t-shirts made? There are no simple challenges. We're going to open it up for questions from the audience. Who would like to pose a question? Brian Top is first.
If you'll permit 2 quick comments, I want to begin by really underlining what an awesome idea the Navigator thing is. I showed up in the emergency room of St. Joe's Hospital in West End, Toronto, with a 4-year-old with a compound fractured arm, courtesy of a scooter. And, hospitals are complex, chaotic places. And the first thing they did when they figured out what was going on was attach us to a navigator who guided us through this system, got him in pain meds place and then the x-ray place and so on in this wild, chaotic place. And it just worked tickety-boo. And so I think it's a great idea. And if you can persuade the government of Quebec to finance that, you will have done the work of the Lord. My second quick comment is, of course, homeless population is complex as well. There's a lot of different folks there, youth at risk, who have their own needs, and people with a spectrum of health issues, mental health issues, and addicted population, all sorts of addicted population, and then a growing population of First Nations people. And a growing issue in Quebec, a screaming issue in Western Canada. And, if we dug into that, I'll have to tell you the only thing I've ever seen work with those folks is on reserve grandmothers. A little warning that maybe we don't have solutions for some of these folks. But I just want to see if I heard you right, that I thought you said at the beginning that you were focusing on alcoholism issues. Did I hear you right? And then your other key public policy proposal is a dedicated community clinic, which is awesome, of course. I just want to understand exactly what you then think happens. Is the clinic mitigating on-street alcohol addicted people, or do you actually think such a community clinic can help cure their alcoholism, and if so, how? Because I'm not quite sure how a community clinic cures alcoholism.
Thank you, Brian. I think the idea of the integrated community clinic is first to give the first point of contact to provide primary health care. But remember, we also have navigators within the clinic to help these patients to access specialized care if they need to. It's true we didn't really narrow down onto alcohol addiction in most of our recommendations, but we see this clinic as an opportunity to help these patients so the navigator placed there would help them to really navigate the healthcare system to access these services at another facility if they need more specialized care.
John Stewart.
Yeah, sorry, if I can add just a quick point on that. We also wanted to just acknowledge very briefly that while we did decide to have a focus on alcohol addiction at the outset, we learned into the project that doing so would kind of entail more of a medicalized focus that we didn't think was appropriate, and we didn't necessarily have the expertise to get into the best form of intervention for that kind of condition. And as a result, we looked more holistically at what a complex health profile looks like, recognizing that those needs are diverse across different people and also highly individualized. And so we looked at healthcare interactions across the system, right? So primary care, specialized care, and beyond. And so that was intended to recognize that each person is unique and that they need this whole gambit of services to support them and to help them kind of stabilize their various conditions, and after that, get back into stabilized housing.
John.
Okay, a word of advice from a lobbyist to anyone who might find themselves advocating for resources for this. I think we all know that you're overcoming a deep reservoir of moral judgment against people who are addicted or who are homeless. And people are also afraid of them. Okay, nobody talks about it, but it's there. You have to appeal, I think, when you're talking to a municipal or a provincial government, to their self-interest and say, if you want a cleaner, more presentable city where tourists feel safe and that looks nice, then you're going to have to invest in this. You are going to have to appeal to their self-interest and not just to the obvious moral fact that these people are suffering and deserve care.
Any response to that? Don't need to. Okay, other questions? We've got a few minutes left. I've got a question if nobody else has a question. And it's about navigation. So like Brian, when I first saw the navigation concept, I thought it was fabulous. And where my brain went was thinking about my 98-year-old mother-in-law. So my mother-in-law, for the past year or so, has been in and out of hospital in Winnipeg. She is clearly deteriorating, and she's out of hospital, but not quite. She's now in this weird netherworld between hospital and long-term care. And it doesn't seem to be very well defined. And if anybody really understands what's going on, they're not talking to the family. The family doesn't know what to ask, who to ask. So this is a place for a navigator. So I don't know what the Manitoba system has in terms of navigation. So the system that you just experienced has a navigator. This connects also to Nadidi's question about resources, because I guess my question is, if all of our healthcare systems across Canada require navigators, and healthcare systems are very complicated, so it wouldn't be surprising if they required navigators, not just for people in homelessness, but for everybody. My question then is the kind of navigation necessary for me or Brian's, son or my mother-in-law, is that different navigation than the navigation that's necessary for people in homelessness? Because if it's roughly the same, then I would think it's an easier political pitch. Whereas if it is a new system of navigation, then it may be a tougher pitch from a budget point of view and even overcoming some of the things that John is talking about. So is it different navigation or is it fundamentally the same?
Thanks, Chris, for your question. So with your mom in mind, right? So there's different types of mother-in-law. Sorry, there are different types of navigators that actually zero in on like people with dementia, older adults that have like really complicated needs, and so like certain navigators focus in on that specifically from what we've researched, which is really helpful in terms of like people that are homeless. The research shows that people who were formerly homeless should be the navigators. Right, so they've got on their feet, they've got a handle on their addiction, and they are now being hired and have like that livelihood of working as a health systems navigator. But like you said, like it's different for different problems. Like as Brian was mentioning, I think it was Brian, there's cancer care navigators that delve into people that have like really complicated or multiple cancers. That's where it sort of originated. So I think it depends on like what are the needs that we're prioritizing, and how can navigation sort of like pivot depending on the person in front of you, because navigation will not be the same. And in terms of the visits, like in terms of navigation, it's sometimes virtual on Zoom. There's text calls, like in person, like navigation visits. Just like you would go see your doctor, you would go see your navigator, or virtually, you name it. And so it would really have to be adapted to that person, and it could be just like a few visits, or the navigation relationship could be like a year or more. So it's really specific to that person in front of you. So hopefully that helps.
Thank you. Anything else for our final, I'm not sure how much time we have, but it's going to be 1 minute and 5 seconds. Anything else? Okay, then let's wind it up. We can take a 1 hour lunch break. Thank you very much. Terrific job. And so we are back here at 1 o'clock for CMHC. Okay, 1 o'clock for CMHC. Be here a few minutes early. Thank you, folks.